Hey everyone, Dr. Armaghani here today to talk to you about the anterior lumbar interbody fusion, also known as the ALIF. This is a common minimally invasive procedure that I perform on select patients. Patient personalization and individualized care is something that's very important to me. This type of procedure is one of several different ways that we can accomplish the goal of a lumbar fusion. Since not all patients are the same, a surgeon has to have different surgical techniques to choose from in their toolbox to best treat your condition. The anterior lumbar interbody fusion is one of those. In this video, we're going to be talking about the normal surgical anatomy, step by step how I perform this procedure, and at the very end, we'll discuss risks, recovery, and do's and don'ts post-operatively. If you're on YouTube and you would like to skip around a bit, please click in the links below to find timestamps to move around as you would like. Now that we've completed the overview for this video, let's go ahead and get started. Alright, so let's get started here. We're again going to be talking about the anterior lumbar interbody fusion, also known as the ALIF. Before we're able to go ahead and talk about how we perform this procedure, we have to have a little bit of understanding of what normal anatomy is. So what you're able to see here in front of you is going to be the side view of a normal lumbar vertebrae. So if you look over here on the right side of your screen, this is actually going to be where your back is. And if you look over here towards the left, this is going to be where the front of your body is. The next structure that we want to take a look at is this yellow structure here. This is your nerve root. The nerve root is responsible for sending signals from your brain down into your leg, and it can give you sensation as well as strength, but can also be an area where you can feel pain. Also, if you notice that this yellow nerve root is actually surrounded by white on all sides here. And what that white space is actually an area of your spine called the foramen. Now, the foramen is just a big word for the space in the bone by which your nerve exits your spinal canal and then goes down your leg. The more space you have for your nerve, the better. So in some patients who may have a smaller foramen, that nerve can be more easily pinched, which then can cause problems for them later on. The next structures that we want to look at are the vertebral bodies. Think of these as the building blocks that make up your spinal column. They stack right on top of each other and give you the structure and strength to hold you upright. In between the vertebrae, at each level are going to be an intervertebral disc. And what this disc is this is the cushion between the bones, which give you the ability to move around and be flexible. This is a degenerative spine. You can tell in this image that it's very different from what we were looking at previously. And it is different in a few ways, which we'll get into. But just to point out some of the normal anatomy that we were looking at before, you still have the nerve root here, which is in yellow. But if you look closely, that space for the nerve is much smaller. That foramen, in other words, is much smaller than it was in the normal spine. So what happens in a degenerative spine? Well, the first thing that happens is going to be disc loss. So what you're able to see here is that there isn't much disc left between the bones here. When these discs start to degenerate a little bit, the space between the vertebrae collapses. As you lose the height between the discs, you then start to form what are called bone spurs. But what you can see here is that the foramen is going to be much smaller as a result of that bone spur and the loss of disc height, which we're able to see here. When you have a smaller foramen, that leads to nerve pinching, which can then lead to problems including pain down the leg, numbness and tingling, or weakness in certain muscle groups. So again, just to reiterate how important this is the normal vertebrae again, and you can see the nerve root here in yellow, as well as the foramen highlighted here in red. You can see how much space there is for the nerve here. There's going to be no nerve pinching here. It's going to be incredibly unlikely that a patient like this is going to have any symptoms. Now let's go back to our degenerative spine. Once more, the nerve root is in yellow, and you see a much smaller foramen secondary to or as a result of the disc height loss and bone spurs that are formed as a result of disc degeneration. So what's going to be our goal in this procedure? We want to try to make this look like a normal vertebrae. And the way we're going to do that is we're going to try to increase the space between the two vertebrae, and as a result, that increases the space for the foramen, which thereby takes pressure off the nerve, helping out with pain. The goal of surgery here is going to be trying to make your vertebrae look like normal anatomy again. The way we're going to do that is by inserting a spacer in between your vertebrae coming in from your belly. And what that does is we're able to increase that space to make it look like normal anatomy again. When we increase the space between the vertebrae, that increases the space for the nerve because the foramen is bigger. And this is how it's going to look. So you can see here it looks very different than it did previously. We were able to increase the space between the vertebrae by putting in this nice big cage. Now the cage doesn't go in that big. We're able to slowly increase the sizes up until a point where we feel that it's a good fit. Once that happens though, it increases that space for the foramen here outlined in red. And you're able to see that there's not a lot of pressure on that nerve anymore. Once the pressure is off the nerve, that decreases pain, improves numbness and tingling, and can sometimes improve weakness that may have developed over time. At this point, you're going to be asking yourself, where do we place this incision if we're going to do this? Well, here's a normal abdomen. And what we do is we generally make about a 2 to 3 inch incision right along the bikini line. And what that does is we end up splitting muscles. We don't go through them, we don't cut them out. We end up splitting the muscles in line with how the fibers are to make this as minimally invasive as possible. Before we get into the step-by-step process by which I perform this operation, we want to know a little bit about the cross-sectional anatomy. What a cross-section means is that basically we're taking a cut of you right in half and we're looking at the anatomy that is underneath within that slice. So if you take a look onto the left side of your screen here, the orientation is such as the top side of the figure here is going to be the front or where your belly is, and way down here at the bottom is going to be where your back is. The first anatomic landmark that we want to look at are your abdominal muscles or your abs. These are the initial muscles that we actually split through to gain access to the abdominal cavity. Next is going to be your intestines, and this is here highlighted in blue. These are very mobile, so we're very easily able to gently move them out of the way or retract them out of the way on our way down to find your disc space. The next structures that we have to pay very close attention to are going to be your blood vessels, which are highlighted here in black. We always need to know where the blood vessels are to remain safe during this procedure, and they're always protected by special retractors, which we will show later on. The disc is going to be highlighted here in red. The disc is our target for this entire procedure. Once we find the disc, we're able to remove it and sequentially place larger and larger spacers to increase the space for your nerve. The last structures that we need to be aware of are going to be your psoas muscles. These muscles extend from the top of the lumbar spine alongside the spinal column. We sometimes have to move these or retract these backwards to gain access to the disc. Now that we have an excellent understanding of the cross-sectional anatomy, let's talk about step by step how I perform this procedure. The first step here is going to be the incision. Now, when we make this incision, we actually cut in the middle of your belly, but then we're able to dissect underneath towards the side, and we follow this gentle green line here. And when we follow this green line, this is going to be our general trajectory to then get around the intestines, which are here, safely around the psoas muscle and blood vessels to access your disc from the front. We'll go ahead and proceed here with the incision. Once we've made the incision, there's a small little window in between the abdominal contents and the rest of the abdominal wall. This is what we try to continue to develop with retractors. So our goal is we need to move the abdominal contents away from the outside of the abdominal wall here. This will eventually give us access to the disc space here. We do this by inserting a retractor, and with this retractor we're gently able to tease and move the abdominal contents, blood vessels, away from the front of the disc space so that we have very clear access to the disc. We then place a second retractor which helps protect the lateral aspect of the disc space as well as the psoas muscle. Once the retractors are in place, we have a very clear corridor by which to access the disc space, which we then need to remove. Our next step is to remove the disc in its entirety. We use this utilizing special instruments like curettes and also this instrument, which is called a pituitary. This instrument is very good at picking out parts of the disc. So we go in and we just start picking out parts of loose disc until the remainder of the disc is completely removed. Once we have the entirety of the disc removed, now we have to put something in its place. This is where our titanium spacer comes into play. Beginning with a small trial or a small height, we start putting in different size cages. Each time we put a cage in, we see how it fits with your particular anatomy. If it's loose, that means we know we need to go up higher. If it's way too tight, we may need to come down in height. But the goal is to increase that space between the vertebrae to make it look like it was before. Once we find the right size cage that fits your body perfectly, we're able to slowly insert this through the corridor so that we get a perfect fit within your disc space. Next, we remove the inserter as well as the retractors and slowly let your abdominal contents return back to its rightful position. We then sew the wound shut and the fusion is complete. Ultimately, this is what it looks like after we have completed the fusion part of the procedure. You have this nice tall cage in between the vertebrae, which has increased the space between them much more than it was previously, mimicking what normal anatomy used to look like. But we need to secure it in place with those screws, and here come the screws securing it in place to act as a little bit of an internal cast to hold everything still. The finished product here shows a significantly taller foramen, which means more space for the nerve root, highlighted here in yellow. That then gives your body time to start going through the healing process to help with any of the pain, weakness, or numbness and tingling that you may have been experiencing. In some special cases, in patients who have a little bit more instability between their bones or a little bit too much motion between the bones, not only do we place these screws that go in from the front, but we may make 2 small poke hole incisions in your back and insert screws through the back into this vertebrae as well as this vertebrae. You can think of this as belt and suspenders to help keep everything stable while your body goes through the healing process to finish up the fusion. Now, the fusion process takes about a year. And after about 1 year, what you're able to find is through this window in between the cage, it starts forming solid bone. Once you have solid bone between the 2 vertebrae, the fusion is totally complete. And that's how I perform an anterior lumbar interbody fusion step by step. What are the risks of this procedure? Well, you tend to worry a little bit about the structures that you have to move out of the way to gain access to that disc space. In this type of procedure, you worry about the blood vessels and the intestines to a lesser extent. One way that we help prevent injury is by asking a detailed history to know if you've had any abdominal surgeries, which could lead to some scarring. We also critically evaluate the MRI to make sure that you don't have any blood vessels that are in different areas than we would normally expect. Ileus is another concern that can happen from time to time. What happens in this situation is, in the process of moving the intestines over and completing the procedure, when you wake up, the intestines don't want to move food across. When that happens, if you start eating and your intestines aren't moving anything through, you tend to get nauseated and could vomit. What we do after surgery is we place you on a liquid diet and wait for your stomach or intestines to wake up again. The way we know that is you start passing gas and we start hearing rumbling in your belly. Once that happens, we know that the intestines have woken back up and we can start feeding you regular food. Nerve injury is another issue that comes up from time to time. If you think about it this way, because you have lost disc height in between your vertebrae, you don't have as much space for that nerve. When that nerve is in a foramen that's much smaller, you can almost think of that nerve as being a little bit shortened compared to what it used to be. Now, in the matter of about 30 or 40 minutes, we increase that height significantly. It can sometimes put that nerve on stretch. When a nerve is stretched, it can sometimes lead to increased pain as well as sometimes muscle weakness. If you develop muscle weakness from a nerve stretch, it generally comes back within 6 months. Muscle weakness is something that we can see as well. Sometimes if you're in one of the upper lumbar levels and you have to really retract that psoas muscle, you may have some problems taking steps, meaning if you're walking upstairs, you may have difficulty lifting your knee up. That generally gets better after about a month or so. Thigh numbness is also something that can occur from time to time as well. This has to do with retractor placement and stretching of some of the sensory nerves around your abdomen. If that occurs, you will have some numbness or tingling on the front of your thigh, particularly on the left side if it's going to happen. This also gets better within about a month or so. Lastly, we worry about bone collapse around the cage. If you think about it, you don't have a lot of space in between your vertebrae. This is why we're doing this surgery. So in the matter of about an hour or so, you have a lot more height in between those vertebrae. The body also wants to come back to what it's used to. So if you have soft bone or are osteoporotic, sometimes that bone can collapse into the cage. So instead of having, let's say, 10 millimeters in between your vertebrae after surgery, as time goes on, that may decrease to 7 or 6 millimeters, which can sometimes lead to increased pain. This is infrequent when it occurs, but we tend to pay more attention to it in people who may have soft bone or a history of osteoporosis. What's recovery like after this procedure? Generally, you're going to spend 1 to 2 nights in the hospital, and then you're going to go home with family. You're going to have back and/or abdominal pain following this procedure just from the incisions. Also, if you think about it too, because we're increasing the height between your vertebrae, you can also feel a little bit of a stretch or a whiplash type injury in your lower back because of the stretch of the ligaments that were holding your bones together previously. This steadily improves over the course of about a month or so. Another thing that I want you to pay close attention to is the recovery process of your nerves. They take about a year to reach their maximum recovery potential, so no snap judgments on this procedure at all. This is going to be a marathon, not a sprint. One thing I try to really tell all my patients following any kind of spine surgery is that nerves are fickle. It takes a very long time for a nerve to recover. Generally, it takes about 1 year for a nerve to recover to its full extent. How you feel at 1 year is going to be how you feel long term. Another thing I try to tell my patients is that the recovery from a nerve injury like this is going to be up and down, particularly within the first 6 weeks. Think of it this way. Your nerve has been compressed for so long that it's no longer able to get proper signals from your brain. So the leg in turn tries to turn up the volume so it can hear the signals from the brain better. But in the course of about an hour or so, all that compression is gone, and now your leg is getting normal signals from the brain, but it's very hypersensitive. Some days following surgery are going to be great. You're not going to have much pain at all. Other days you're going to feel like you never had surgery to begin with. You just need to give your nerves time to re-equilibrate and turn down that volume so it's not hearing the signals from the brain as much as it needed to previously. This takes about a month to get better. What can I do post-op? Once you leave the hospital, the bandage that we have on should stay on for 3 days. The reason why that happens is because we want your skin to really get watertight before we allow you to shower. After 3 days, you can remove the bandage that we placed at the hospital and you can shower normally. Let soap and water run down your back or abdomen, pat it dry afterwards, and if you'd like, put a new bandage over the top for the first week or 2. The reason why I say put a new bandage over the top is because the incision sometimes lies in your pant line and you don't want to rub on the incision. You also have butterfly strips that are covering the incision. Those should fall off on their own as you start showering. If they're not off in about a week or so, you can remove them. The vast majority of you are going to have stitches that are all on the inside, so you don't need to come back to clinic soon to get them removed. Occasionally, you will have staples, and we will let you know if you have staples to come back and see us within a couple weeks. From a restriction standpoint, we don't want you bending, twisting, or lifting greater than 20 pounds for about 3 months. We want your body to start healing and creating some of that early fusion mass between the bones. After 3 months, the bones start to get a little bit more sticky and we can increase your activity level. If you have a job that doesn't require you lifting frequently or bending or twisting, you can go back when you feel up to it. But if your job requires you to lift greater than 20 pounds, we would like you to modify that duty to either light duty, or we can write for you to be off of work until 3 months passes and you're safe to start lifting again. We want you to walk as much as you want. The goal of this is to help recreate the connections that were lost from the muscles in your leg up to your brain. Lastly, from a pain management standpoint, we don't want you taking any anti-inflammatories after surgery because it does decrease the rate of fusion following these procedures. Examples of anti-inflammatories include ibuprofen, Motrin, ALIF, Advil, Mobic, Celebrex, or naproxen. What you can, though, take is 1,000 milligrams of Tylenol 3 times a day. Just take it with breakfast, lunch, and dinner. Even though you may think Tylenol isn't doing a whole lot for you, it does give you a good steady-state background amount of pain relief so that you don't have to take as much narcotic or muscle relaxer following surgery. Generally, my patients are off of narcotics by about 3 to 4 weeks. Sometimes that extends out to 6 weeks in severe cases. So there you have it, the anterior lumbar interbody fusion, also known as the ALIF. Hopefully after this video you have a better understanding of the anatomy of the lumbar spine, step by step how I perform this procedure, and what to expect postoperatively. If you're curious about the conditions that can be treated with this particular procedure, please see the links below if you're on YouTube. And while you're there, please hit like, comment, and subscribe to be notified about other educational videos such as these. To make an appointment with me, you can find our office phone number in the links below, or you can click Book an Appointment above if you're on our website, www.armaghanisspine.com. You can also find me on these platforms here if you're interested. And thanks again for taking time out of your day to learn about this procedure with me. Take care.